Hello, good evening, all. Welcome back to my IVFenses. I'm glad to be back with Dr. Halyna Strelko. This is our specialist expert tonight. So, welcome back, Dr. Strelko. How are you feeling? It's great to have you as always.
Thank you. All is fine. Today we have interesting topic, quite difficult as for me, but still interesting. So we will try to discuss about the difference between agonists, antagonists, and
Yep.
so on.
And we have the best expert to explain that. So I'm glad that you were able to join us, especially considering what's going on, of course, right now in Kiev. So I'm glad that we are able to still go ahead with the topic, and you will be able to explain this tough topic, as you mentioned, of course. And remember that you will have a chance to ask your questions. If you have them ready, you can put those even now. If not, wait for the Q&A session, because we will start with the Dr. Strelko's presentation, and afterwards there will be time for your questions as well. Before we begin with our presentation and our topic, I also want to encourage anyone who is interested to join us, as we are looking for some volunteers who would like to help us with transcriptions. If you wish to get some more details, of course, please just get in touch with me. I'll be happy to explain what exactly we need. And my email is caroline@europeanfertilitysociety.com. So if this is something that you would be interested in, just send me an email, of course. We are looking for volunteers for English webinars, but as you probably know, there are some Spanish and Italian ones. So we are also looking for transcriptionists that can speak Italian and Spanish. Okay. And of course, remember that if you wish to support us, you can go to our website, myivfrances.com, and put a donation, and that way we will simply we will be able to just grow. That's what we want, and we want to help as many patients as possible. So you can go to our website. Of course, this is the way to do it. And right now, I think we can go ahead with our presentation. Dr. Halyna, great to have you back. Dr. Halyna has been with us throughout the whole year, and I'm very happy that you are connecting every now and then, and it's great to have you as our expert for sure. So thanks a lot.
Thank you. Thank you for your kind presentation. Yeah, hopefully we have electricity and
Exactly.
I can do my presentation, because it's true that unfortunately today we has quite difficult day.
Exactly.
But
So
still, we will continue. Life is continue, so we will start.
Thank you so much indeed. And this is the presentation. You can go ahead.
Yeah, thank you. So today, dear ladies and gentlemen, we have quite difficult and quite interesting topic, as I say, and it's related to different kind of medication which we can use during the ovarian stimulation protocol. Agonists, antagonists, some minimal stimulation. And I would like to start a little bit at the beginning to explain some theoretical issues, to understand well what is the main difference and what is the main goal to use such medications, and which is the difference finally. So the main goal of controlled ovarian stimulation, whatever protocol we will use, it is mostly to receive the good quality oocytes, receive good fertilization, and receive good probability to become pregnant. We know that only 23% of all embryo transfer, according to big data, big statistic data of ESHRE, ISRM, finally lead to delivery. And that's why the protocol and eggs received after this protocol, number of eggs and quality of eggs, it is the crucial and most important question. So the probability to have at least one baby born, depending on number of oocytes and age of woman, you can see in this graph. For example, if woman has 35 years old and would like to have and we will receive around, I don't know, 20 eggs, yeah, we can see that 35 it is yellow, that we will have the probability to receive pregnancy 70-80%. But if we have women of late reproductive age, even with 30 or 40 eggs, we will have only probability around 20-30%. So it is very important to receive enough eggs, and quality of these eggs should be quite good. Okay, so 10 to 20 eggs till the age of 40 years old permit in most of cases has as minimum 50% probability to have live birth. Number of eggs after controlled ovarian stimulation depends on anti-Mullerian hormone. It means that depends on how many little follicles has woman in her ovary. Depends also on body mass index, because if we give the same dosage two different women, like 50 kilo and 100 kilo, in blood we will have 1/2 of concentration in case on 100 kilo. So it means that when we start the stimulation, we should take in mind the body mass index of patient. Also, sensitivity. Some women react better, some women react not so well, because probably on reception mutations or other problem. And some protocols may be more successful and some not. So in this graph, in this picture, you can see different protocols described for controlled ovarian stimulation. We can try to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There are a lot, and it is really difficult to understand and to choose even for doctors. For patients, it is absolutely stressful question, because patients try to understand what happened, try to read something, try to study some topics, and it is always difficult to understand why doctor use such or such protocol. So today we will try to see what is the main goal and main difference. So what does it mean, controlled ovarian stimulation or protocol in IVF? This is the treatment scheme. And this treatment protocol consists on 4 parts. One part, it is gonadotrophins, FSH, LH, or combination of FSH and LH, or urinary FSH. It means some hormones which may activate ovary and make follicle growing. Another part of this protocol is prevent premature luteinization hormone elevation, which may provoke spontaneous ovulation. And in this case, we will not be able to receive these eggs during the egg retrieval. Another part of this treatment we call triggering of final egg maturation. It is the last injection. Normally we are doing this injection 36 or 35 or 36 and half of hour before the egg collection. This injection necessary to produce the final egg maturation. because normally during the stimulation, eggs stay in some stage which will not be able to produce fertilization and embryo development. To receive mature eggs, necessary to do this last injection named triggering. And also embryological part of the protocol. It means that after the egg retrieval, embryologist should found eggs to see mature or not mature, to fertilize and so on. So we will talking today mostly about premature LH surge prevention by using agonists or antagonists. So, why this question arrive from historical point of view? Why we are talking about this agonists or antagonists? Why it is so important to prevent LH surge? We can see that first publication about stimulation of ovary appeared in 1970. First publication by Edwards and Steptoe, pioneers of IVF. And they proposed the protocol of stimulation and triggering of final egg maturation. They has done 77 trial and no one was successful. And they finally reanalyze this process and try to do in natural cycle. And successful pregnancy, Louise Brown, arrive after natural cycle IVF. But to understand the moment when LH increase and from which moment necessary to count this 35-36 hours, they measuring LH every 30 minutes, day and night. And we understand that it is impossible in normal life, yeah? So they understand 40 years ago that need some control of LH to do successful IVF treatment. And around beginning of 19th, was discovered the gonadotrophins releasing hormone agonists can prevent spontaneous LH surge. And era of long generation protocol start. What does it mean, long protocol? It means that first we use these agonists, stop ovarian function and then start the stimulation. But in this case, no spontaneous LH surge. And this long protocol during probably 20 years was the most utilized, most spread protocols. And even now, a lot of doctors prefer to use long protocols. Why agonists was used for this purpose? Because normally agonists regulate the function of gonads. They stimulate production of follicular stimulation hormone, and this hormone stimulate ovary to produce follicles. So when you stop the function of this agonist, no FSH, so ovary does not work in. Also important point to know that sensitivity of ovary to FSH action arrive only last 2 weeks of their development. And previous 10 weeks around, no sensitivity of growing follicle to FSH. Also, we should mention the term recruitment. It means that women can have some amount of little antral follicles, cohort. We call that cohort of follicles. And when we give FSH, some quantity of these follicles start to growing. And this growing follicle, number of this growing follicle depends on how many follicles woman has, sensitivity to FSH, dosage of FSH, also some additional medication, and also protocol agonists or antagonists may influence to this recruitment process. And also one theoretical issue we should discuss, the theory of follicles growing. It means that to starting follicle growing, necessary to give some amount of FSH. This called threshold of FSH. It means that basic FSH should be pass around 30, maybe 50%, yeah? And this FSH should act during some amount of time. It's called window of FSH. In this picture, it is like a visual example. In natural cycle, we have not very high increasement of FSH, and this window of FSH not last very long time. So we have 1 or 2 follicles. If we give clomid or letrozole tablets, which are spreadly used for stimulation, FSH increase a lot, but this window of FSH does not last long time. So we will have couple of follicles, maybe 3, and size is not the same. Yeah. And when we use standard stimulation, we can give high dosage of FSH, and window of FSH may last as much as we need. It means that if we decide to give FSH 10 days, we will give 10 days. If we will decide to give more, we can continue. Yeah. So this is the main difference to explain why only dosage of FSH not always enough, and why sometimes necessary to continue the stimulation. So, premature LH surge prevention methods. Actually, we know 3. It is agonists of gonadotropin-releasing hormone. The principle of action that at the beginning agonists stimulate production of FSH, and then they, how to say, principle of as normally it should be produced by pulsatile waves, and with big amount which we can done after this system inhibits, stop, and FSH and LH stop the production, and we have inhibition of ovarian function. And all follicles in this moment will be more or less equal size. And if we start the stimulation at this moment, it may be more homogeneous, this cohort of follicles growing. And this is the main idea of some doctors who prefer to use the long protocols. Antagonists, they block immediately the LH hormones, and level of LH decrease quickly, but cohort of follicles may be not so homogeneous. Also possible to block premature LH surge with progesterone, but it should be the another topic and another day and another presentation, because it is not agonists and antagonists. Why progesterone block LH? Because decrease the waves of pulsatile LH production, and when we have no this production, no activity of ovary. So, physiological difference of agonists and antagonists action you can see in this picture. So with agonists, first we have effect which we call flare-up. It means that increase of the dosage and activity and then stop. And antagonist has no this effect of flare-up. Sometimes this effect of flare-up produce some follicle cysts. That's why it needs sometime more time that this activity decrease. For example, normally it is 2 weeks after we start the suppression of ovarian function till the moment of total suppression. But it may be 3 weeks, it may be a little bit more. With antagonists, it is much more easy. Immediately they stop LH activity. In this graph, you can see how quickly decrease LH level in different protocol. For example, if we are talking about antagonists, yeah, it is quite quick. If agonists, it is more slow decreasement. And what we has seen before and talking before, that recruitment of follicles and size of follicles may be a little bit different in agonist and antagonist protocol. In women with normal ovarian reserve, it seems that long agonist protocol may give more homogeneous cohort of follicles. But scientific investigations and a lot of study not confirm the big clinical difference from this point of view. For example, the comparison of GnRH agonists and antagonist protocol on the same patients during controlled ovarian stimulation show that main difference of two protocols in the same population of normal gonadotrophin women, that protocol with agonists normally give more days of stimulation, more ampoules, it means more expensive, and mostly the same embryological parameters. We don't see the difference of egg number or egg quality or fertilization rate. The main difference that finally agonist gonadotropin releasing hormone protocols, it means long protocols, will be more expensive because need more days and more ampoules. For polycystic ovarian disease women or women with very high ovarian response, it is quite dangerous, as for me, to use long agonist protocol because there is a high risk of ovarian hyperstimulation syndrome. So the study comparing two protocols in this category of patient, meta-analysis show that stimulation duration is also longer for in agonist protocol for this category of women, that gonadotrophin dose also bigger for this category of patients, so the same as normal gonadotrophic women. And what is the most important, that the hospitalization risk is with ovarian hyperstimulation syndrome is much more in protocols with agonists of gonadotropin releasing hormone. Why? Because the ovarian hyperstimulation syndrome start mostly after the triggering with HCG, chorionic gonadotrophin, because chorionic gonadotrophin influence the vascular permeability and may start and to be trigger of this ovarian hyperstimulation syndrome. But in protocols with agonists, is impossible to do another trigger. Only HCG may work. That's why probably the difference of risk is so big. So when we compare the conventional GnRH antagonist protocol versus long agonist protocol, we can see that estradiol level is higher on HCG day. It means that at the end of stimulation, little bit more follicles and production of hormones of these follicles are higher. And we know that the factor of risk of ovarian hyperstimulation syndrome also is estradiol level. So the result of this study, of this meta-analysis, show that agonist trigger and freeze-all approach prevent ovarian hyperstimulation syndrome, and long agonist protocol with triggering with HCG should not be used in patients with good ovarian response or with polycystic ovarian syndrome, because it may give a lot of complications, and embryological parameters when we compare with short protocol are mostly the same. So here you can see the comparison of HCG triggering and agonist triggering in women with PCOS, because also sometimes patients asking if eggs will be so good in both cases. And you can see that agonists triggering give mostly the same results as HCG triggering, no difference, but the risk of ovarian hyperstimulation syndrome in case on agonist triggering, group A, you can see is around 0.5%. And in case of HCG triggering is 47%. It is huge. It is one half of patients. So once more, in case on high ovarian reserve, using the antagonist protocol with triggering with agonists is more safe and better choice than standard long protocol. Even if sometime with this long protocol we can receive extra 1-2 eggs, probably, but it is from the point of view of safety, we should use a short antagonist protocol with triggering with agonists. So here you can see the description of profile of patients who has very high risk of OHSS. It is previous cycles with OHSS, young age, PCOS, low weight, and in this case, of course, better to use antagonist protocol. So, long agonist protocol, the main idea, first, suppression of ovarian function from 20th day of cycle. After this suppression arrives stimulation with FSH, and in this case, only one possibility, triggering with HCG. The advantage that we can plan, because after the suppression arrive, we can start the stimulation from 2nd day of cycle, from 5th day of cycle, from 10th day of cycle. It doesn't matter, it is the same. So it is really big advantage, especially in very busy IVF units where doctors should plan well their work. And that's why a lot of doctors still continue to use these protocols. Second advantage, that in this protocol we can do the fresh transfer, because after agonist triggering, fresh transfers are mostly unsuccessful, necessary to do freeze-all program. So long protocol, the main advantage, planning, synchronization of follicles, and possibility to do the fresh transfer. Disadvantage, mostly ovarian hyperstimulation syndrome. So for women with high ovarian reserve, probably it is not a good choice. For women with normal or low ovarian reserve, it may be the choice. Short agonist protocol, also one of the type of agonist protocol. The agonists and stimulation started the same day, and after a couple of days the suppression arrived. And this type of protocols before was used for poor ovarian responders, because this effect of flare-up, of increasement of ovarian activity at the beginning of agonist use, sometime was very helpful to increase the follicle growing. Also advantage that in some case, for some poor responders, may be better result. And also maybe fresh transfer. Disadvantage OHSS, but if we will use this protocol mostly for women with decreased ovarian reserve, risk of OHSS is not very high. Short antagonist protocol. Now probably most of doctors as minimum know about this protocol, and most of them prefer this protocol. Me personally, last 3-4 years, I mostly never use long protocol. So advantage of this protocol that we will use less ampoules, less FSH, less day of stimulation, and also it decreases per se the risk of ovarian hyperstimulation syndrome. And main disadvantage that if we will do the triggering with agonists, better not to do the fresh transfer. But if we will do the triggering with HCG, we can do fresh embryo transfer. Sincerely speaking, the main disadvantage of short protocol that normally we start at the beginning of cycle, and it is more difficult to plan for patient and for doctors. But there are some methods which permit to start 1-2 days later or before the beginning of menstruation, so we can resolve this problem. So this is a schema of comparison of long agonist and GnRH antagonist protocol. And you can see that long protocol is longer, because on this previous period when we suppress ovary, we use a lot of injection, and sometimes for patients it is quite boring, more expensive. And there is the difference of this final triggering injection. What about minimal stimulation? Minimal stimulation related mostly to FSH dosage. Next week we will talk specially about minimal stimulation, but shortly, the main idea of this minimal stimulation to decrease the number of FSH injection and to decrease price probably. it is difficult to explain this topic in 2 words, but for example, for poor ovarian responders, when we have a really decreased number of follicles, whatever dose we will use, we will receive 1 or 2 follicles. And in this case, as for me, no need to use standard dosage, because anyway we will receive the same number of follicles. So this is Poseidon group 3 and 4 category of poor responders. It means that poor responders with low antral follicle counts. So for this category of patients, probably minimal stimulation protocol will be money safe and more, how to say, friendly. For other category of patients, necessary to see, because when we use low FSH dose, sometimes we can receive very low follicles and eggs number, and if quality of these eggs is not enough good, at the end we will not have enough embryo for the transfer. So, but necessary to talk about that more in details. So, for poor responders, we can use natural cycle, the same idea. If we have 1 or 2 follicles, in natural cycle or with minimal stimulation, we will have mostly the same result, I mean, egg numbers. Also, we can use some adjuvants, and also we can use different modifications of agonist protocol, for example. But depends on antral follicle counts. So, if we are talking about poor responders, yeah, because previously we have talking about good responders or high responders. The main problem is asynchrony of follicle growing. And that's why some author propose to use long agonist protocol, but it will work only in case on more or less good ovarian reserve of these poor responders, group 1 or 2 according to the Poseidon classification. Also, we can use short flare-up protocol, and also we can use antagonist protocol. But in case on very low follicle numbers, better to use or natural cycle or very low dose FSH, or even some protocols with clomid or letrozole, because anyway we will have 1 or 2 follicles. And in case on resistance of FSH, we can thinking about that when we have good IMH, good antral follicle count, and no a lot of follicle growing. In this case, better to use high FSH dosage, and probably also short agonist protocol with this flare-up effect. So, long agonist protocol for the long time, for the 20 years, was the gold standard of controlled ovarian stimulation. Main benefit of this long agonist protocol is possibility to planning your work and planning your time and planning your schedule. Main disadvantage, ovarian hyperstimulation syndrome risk. Short agonist protocol, main benefit flare-up effect. That's why some scientific works show benefit of this protocol for poor ovarian responders, because this flare-up effect plus FSH give good FSH in plasma, and finally better answer than standard protocol. And main disadvantage, the same, OHSS risk. Short antagonist protocol became the gold standard now. Main benefit, shorter treatment duration, OHSS prevention, and main disadvantage, less easy to planning. And low dose stimulation protocol and different agonist regimen. Main benefit, this is the short treatment duration, decrease cost, and disadvantage, question of synchronization, but necessary to see other method of synchronization, and we have this method finally. Okay, thank you for your kind attention. I understand that it is quite difficult topic, but hope I explained a little bit the difference.
Thank you so much indeed. You are right. This is not an easy topic with those protocols. It's definitely something that brings lots of questions, and that's why we are here to explain it to you. And of course, we will start our Q&A session. So if you have any questions, this is your time. Go ahead and use this chance to simply ask Dr. Halyna. I'm sure she'll be happy to help you out. There are some questions showing up, so of course we can go with the question. The first one we have is right here. Have you ever seen an improvement in egg quality for someone who has had bad quality granulose, vacuolous, soft eggs on maximum, right? Max stims, in 5 previous cycles?
Very good question. Thank you. In most of case, the quality of eggs is more or less the same in all protocols. Okay, sometimes we can have cohort of eggs better than previous one. I have seen in some patients with several stimulations that one stimulation was unexpected better than other. We don't change nothing in the protocol, but it was better. To improve something with the protocol, we can improve by using some tactic with triggering. It means give higher dose, giving double triggering, waiting more hours between trigger and pickup. This sometimes may improve. Also using growth hormone sometimes may improve during the stimulation, but all this tactic has no very dramatic improvement effects. It may give some 10%, 5% improvement, but not, how to say, dramatically change. It is rather some cohorts of follicle may be better than another one, like that.
And I hope that answers your question, of course. Thank you so much for your question. As you can see, of course, there was some more details, but I guess we have answered that already. So let's have a look. There are some more questions, and there's a thank you from Lynn for you. Lynn, thanks so much. Okay, how about this question from Elle? Is there like best suitable protocol for someone with adenomyosis and fibroids M40?
Also good question, because long agonist protocol was thinking to improve situation with endometriosis, especially very long protocol. It means 2-3 months of suppression and then start the stimulation. Me personally, I don't like such protocols because after 3 months of suppression, very often ovary does not respond well, and we use huge dose of FSH. Probably the problem of endometriosis improve a little bit, but quality of eggs and duration of stimulation is very long and it is difficult. Better as for me, first to receive your eggs, maybe doing 2-3 different stimulations, produce embryos, freezing, and then preparing uterus, doing the treatment of adenomyosis, and then preparing you to the transfer. As for me, it will be better like that. Also, to answer your question, necessary to see your IMH level, your antral follicle count, and probably the information about previous protocols.
Of course, that makes sense. Sile, if you wish to add anything. ahead to it. And thanks so much. And Karen would like to know, what is the flare effect, if you can explain this.
Yeah, sure. Flare-up effect, flare effect. It means that agonists at the beginning they like stimulate additionally. They normally agonists stimulate the production of FSH, and then FSH activate ovary. And when you give agonists, your FSH rise dramatically. Normally, if you give, for example, 3 ampoules of FSH per day, you have FSH, for example, 6, and after these 3 ampoules, you will have in blood like 12, 11. It means your basic FSH will increase twice. But with this flare effect, you will have not 11, but probably 20. It means that your FSH with this flare effect will be much higher than it may be only with injections of FSH for stimulation. And it will, how to say, cumulative influence to your ovary. Sometimes this flare effect, when you start your long protocol from 20th day of cycle, may give ovarian cysts because stimulate follicles to grow in, and then these follicles cannot develop in correctly. Also, sometimes this flare effect may stimulate your corpus luteum. If, for example, your eggs was fertilized but not implanted yet, and we give this injection in 20th day of cycle, sometimes it can help that pregnancy arrive by natural way. And we can see this time to time during the long protocol, like 1 to 2 times per year. We have seen the spontaneous pregnancy starting with the long protocol. So this means flare effect.
Next. Excellent. Thank you so much, Karen, for your question. I believe it was helpful for you as well. And while we are here, Karen has another question. Let me show this one. So I have noticed a reduction in follicles numbers over past 12 months from 6, 7 follicles to 1, 2 follicles in the last month scan, hoping it was just a poor month. But is there a process of protocol to increase follicle count?
Oh, good question. It is rise not good months because normally it is not decrease like that very quickly. Probably necessary to wait, take some supplements, have a rest, and maybe to see in 1-2 months. Sometime we will see that number of follicles restore or increase because number of follicles can change around 30-40% month by month, maybe such difference. So probably it is not good months. But the length of follicle development is around 12 weeks. It means that you should see once more your ovary in 2-3 months to understand what happened.
All right. Thank you again, Karen, for your question. All right. There are more questions coming up. So Sebastian would like to know, which is your favorite protocol in endometriosis?
Me personally, I prefer short antagonist protocols. And then, depending which kind of endometriosis we have, I'm doing different type of preparation. If we are talking about adenomyosis, I'm using some medication during 3, 4, 5 months to decrease this endometriosis, and then we start the preparation to embryo transfer. Because if it is ovarian cysts, sometimes we do nothing and only doing the transfer, and pregnancy per se decrease the endometriosis activity. So necessary to see the situation. In guideline, it is right, and that previous treatment of endometriosis finally does not influence a lot the IVF results. So
Okay. Thank you. Thank you for your question as well. And what do you think about of duostim protocols?
good question. We has done webinar about those team, and okay, this is as for me, there are two positive moments in those team. First, if woman has not a lot of time, for example, international patient come in some clinic abroad, and we should receive as much eggs in short time, so we can do those team. Second possibility, but the same idea, for example, fertility preservation. We have no time and we should receive as much eggs as possible. And sometime this second stimulation after first egg retrieval may be more successful because we can see the cohort of antral follicles more homogeneous and more in number. For example, first stimulation we receive 2 eggs or 1 egg or 3, but we can see at the end of stimulation another cohort, 5, 6 follicles. And in this case, if we start second stimulation, we will receive a much better result. So in this case, I use this double stimulation protocol.
Okay. Thank you so much, Marha. I hope that was again helpful for you. Let's have a look. Dizzy has another question here. These days, some patients are using plasma. Is it, I think, PRP, I think maybe
Yeah,
it's
PRP,
about,
yeah.
yeah. Is it beneficial to conceive at the age of 48 with donor eggs?
There are a lot of publications about PRP. PRP for endometrial growing, PRP for ovary, even in cosmetology, PRP is very helpful. So, my own experience with PRP, for some patients, it was helpful, but not for all, and it is difficult to predict to whom it will be really helpful. If, for example, you has very thin endometrium not growing well, probably PRP as minimum you can try, and probably endometrium will become better. For ovary, I don't think so, because at 48 years old with own eggs, the probability of pregnancy is mostly zero. With donors' eggs, the most important to preparing well your endometrium. So yeah, PRP may be helpful.
All right. Thank you. Thank you for that advice as well. Okay, Karen has a follow-up. Okay, previous patient. So for low follicles number 1, 2, will the effect of no medication have the same impact as using stimulation medication?
You mean stimulation protocol or natural cycle, or how to say pretreatment? Because if we're talking about some pretreatment, yeah, we can use like ubiquinone, like coenzyme Q10, like estrogens low dose, some vitamins. It is right and shown in some articles that this pretreatment during 2-3 months may improve the follicle number because decrease the apoptosis process. But sometimes even without any medication, in 2-3 months we can see that number of antral follicles will be better than 1 or 2. So it is like that. If we are talking about stimulation, If you can see at the beginning of the stimulation only 1 or 2 antral follicles, whatever you will do in will be 1 or 2 follicles. We cannot stimulate something if there is no follicles in the ovary. We can, during the stimulation, we can increase or decrease the number of eggs. If we have, for example, a lot and we give high dose, we receive a lot. We give low dose, we receive 1/2 of this amount. Okay, like that we can regulate. But if we have one follicle, whatever we will do in low dose, high dose, standard protocol, we will receive only one follicle.
Okay, thank you, Karen. I believe that was helpful. Thanks so much indeed. And sorry, there are more questions coming up. I just need to go back to the previous one. Just give me a second. Here it is. Can me-inositol and metformin decrease AMH level? I have insulin resistance and have been taking inositol 2,000 a day and metformin 1,000 a day for a few months. My AMH went down from 1.3 nanograms to 0.6 in 6 months. Shall I carry on with both medications?
Very good question. Indeed, myoinositol and hydroinositol and metformin widely used for women with polycystic ovarian polycystic ovarian syndrome, and normally antral follicle count decrease little bit, but IMH 1.3, it is not PCOS, and 0.6 it is riser decreased ovarian reserve. So necessary to see and probably talking with doctor about exact diagnostic, because polycystic ovarian syndrome IMH should be more than 3.5, 3.6, and not 1.3. So, okay, from the other hand, if you are insulin resistance, of course, it may influence the quality and quantity of eggs, and after pregnancy, also if you will have pregnancy after, there is a higher risk to have diabetes during the pregnancy. So it is very important before the pregnancy normalize your insulin and sugar levels. But necessary to see if you are really polycystic ovarian disease patient, because with such IMH level, or probably your IMH level is not correctly done. So necessary to see.
Okay, thank you for your question as well. Karen would like to know, when do you begin to see the second cohort of follicles in dual stimulation?
Near the ovulation day, near the triggering day. Normally follicles less than 10 millimeters day of triggering may growing after pickup, and the fact of progesterone increasement will not influence the eggs quality and will not destroy their development. But if we will have follicles like 12, 14 millimeters, high progesterone may influence. So second cohort near the day of triggering and ovulation.
Okay, thank you. Okay, sorry, I'm just checking if, yeah, there are more questions, of course, but let's see this one. So for dual stim, when do you see the second cohort of follicles in the cycle?
In the middle of the stimulation, I mean, or sometime from the beginning, we can see that there are like 10 follicles, 2 will grow and others stay in place. And after the triggering, we can restart the second stimulation. But in most of case, we can see that these follicles like arrive a little bit later. This wave of follicles arrive more close to ovulation.
Okay, thank you. And I will go to this question. Which trigger do you use after first stimulation in dual stim?
Mostly agonists, because with HCG necessary to wait. You cannot start immediately. It works a little bit worse.
Mm-hmm. Okay, let me go again to this question from Karen. So, if nothing visible close to trigger, it would suggest there would be no follicles to stimulate in the second of dual stimulation.
Yeah, exactly. If the day of egg retrieval we don't see any follicles, no sense to start the second stimulation. And opposite, if you can see 3, 4, 5 follicles, you can start, and normally we receive second wave of follicles.
Okay, thank you so much. And again, I will go back to previous patient. Okay,
Yeah,
so I'm not PCOS. I don't have PCOS. I just wanted to take inositol to
mezitol.
improve mezitol to improve my egg quality. Then I discovered insulin resistance, and I was prescribed metformin as well. Maybe I should just take minoxidil and not metformin.
Okay, I understand, because at the beginning I don't understand well, and also normally mionazitol in most of case doctors prescribe for PCOS patients, and PCOS are often go with insulin resistance, so that's why. Yeah, there are some works that show that inositol can improve a quality, but sincerely speaking, you should take it, I don't know, 1 year or 2 years, long period. It is not work very quickly. Uh, so as for me, it is not the method to improve dramatically quality of eggs. Probably it may a little bit improve, but whatever we are prescribing, the quality of eggs, it is arises some inner condition, some individual condition, and it is difficult to influence. And to control the effects of that, necessary to do another stimulation, pick up fertilization, to see blastocyst sorry, development, genetic of this blastocyst. So it is always difficult to control the effects of all these interventions.
Right. Thank you for your follow up. I hope that was again helpful for you. And let's go back to Lynn. So she has a question: can extreme pain, inflammation in the body, ruptured disc in back causing sciatica, not sure here, sorry, ever affect the outcome of a cycle?
Oh, good question. You know, all inflammations may influence the result of cycle, but also it is difficult to measuring. Probably if your cortisol level will increase during these events, and also your prolactin level increase, it may influence stimulation protocol. But otherwise, I don't see how it may influence. If the inflammation in the body lasts long time, for example, we know that chronic endometritis, chronic inflammation of endometrium, decrease the implantation probability. And the treatment of this endometritis dramatically improved the results of IVF. The influence on ovary, it is more difficult to measuring.
Okay. Thank you. Thank you so much indeed for yet another question. Okay, how about this one? Is it okay to do pre-treatment with testosterone even when DHEA has been used in the last 3 months?
Good question, because around 10, maybe 15 years ago, the DHEA was very popular as pre-treatment, and in some case, the number of follicles improved. Last time, mostly in scientific papers, written that testosterone is better, transdermal testosterone pretreatment, because it is decreased the apoptosis in ovary, and more antral follicles arrive till the final stage of development. So for poor responders, it may be helpful.
Okay, thank you. Thank you for that. Some more questions are right here as well. So let me just go to this one. So did 2 rounds and on short protocol got 1 embryo to transfer on round first, the second to transfer on round two, sorry, 2 to transfer on round 2, and third round on long protocol, no embryos. Do you think this is as a result of long protocol?
Of course, necessary to see all your stimulation, but if you have low antral follicle count, sometime after this suppression during the long protocol, after the response to stimulation is very poor. And the quality of eggs also may be decreased, especially for women of late reproductive age. It means after 35 years old, because with this suppression in long protocol, you will have very low LH level. And in late reproductive age, for normal egg development, necessary not only FSH but also LH. So stimulation should be FSH plus LH, like Pergoveris or Menopure, and sometimes it is not very easy to stimulate over in this condition. So poor responders, me personally, I prefer not to use long protocol. Because in most of cases it is not improve the situation. Sometimes it helps to synchronize follicles, but there are other methods of synchronization.
Okay, thank you so much. Okay, another question: if after transfer there is intense itching in vagina, possibly due to applying progesterone capsules, can you apply prebiotics to relieve itching?
Yeah, probably you has unfortunately candidosis or something like that, some infection. So you can use progesterone in injection or like peros capsules, tablets. And in this case, use local probiotics or even some vaginal suppositorium, anti-inflammatory inflammatory suppositorium. So something like that. Because yeah, it may provoke, unfortunately, sometime.
Okay, thank you. Thank you so much again for yet another question. A bit of unusual question. Do you know if lengthy sedentary periods can impact follicle count? I changed job, spent 10 hours per day seated, but I know, and I worry this reduction in the movement and subsequently blood flow could be having a negative impact.
Yeah, good question. Good question, because there are some papers about influence of acupuncture, of yoga, of massage, uh, methods improving blood circulation on egg quality, on implantation rate, and so on. And in most of these works, shown that improving blood circulation may improve stimulation results, implantation results, pregnancy results. So, yeah, probably this factor may influence. It was right, and that sitting more than 3 hours without some pause, some movement, same negative effects as smoking, something like that.
Okay. Thank you. Thank you, of course, for your question, Karen. And don't remember, you can ask anything. We are here to help you out with any doubts you have. So thanks so much indeed. There's a comment from Karen. So if you have more questions, you know what to do. We are still here, but of course we will be finishing slowly. So thanks a lot to everyone for all of your questions. Um, possibly changing job might be a good idea. True. I'm waiting because if someone is of course typing, so I want to make sure that we were able to answer all of your questions. And of course, Dr. Halyna, as always, it's great to have you, and I'm glad we are able to have you as a presenter. I'm sure there will be some more events coming up. In the meantime, we did receive one more question. Is it possible to attend your clinic at the moment? I know you are in difficult times.
Yeah, we are working still, and you can come, of course. We have some international patients, of course, much less than before. It's understandable, but we continue to work.
It's possible they can drive to Kiev
Yeah,
still.
yeah.
It's possible, and you can
Yeah,
see.
yeah. The main problem that there is no plane because of
Of course,
safety reasons.
of
So,
course.
but train we have a lot. So from
Okay.
Poland, from different country, possible to come.
All right. Thank you for reassuring us, of course, as well. And thank you from Lynn. And one more question, final question for tonight. I think I missed it, sorry, but here it is. Long protocol and short protocol have any difference in when it comes to good results?
Look, if you have normal ovary, from embryological point of view, it will be mostly the same. For women of like less than 38, 35 years old, with normal ovarian reserve, probably will be absolutely the same. Only with long protocol, we will use more medication, more ampoules. It will be more expensive.
Okay.
If you are poor responder, in some case you may receive better synchronization of your follicles and at the end more mature eggs, but in some case you will receive zero answer to stimulation, and this is the main challenge with poor responders and long protocol. With PCOS patients, long protocol, as for me, absolutely not good idea because you cannot do the triggering with agonists and you will receive for sure ovarian hyperstimulation syndrome. From embryological point of view, in most of cases, it will be the same.
Okay. Thank you for this final question. I believe. Okay. Okay. With donor eggs, if you can clarify.
With donor eggs, the question, what do you mean long protocol? Long protocol of ovarian stimulation or long protocol of endometrium preparation? Because if you mean that first your doctor give you injection of diferilin or decapeptyl 3.75, then waiting 2 weeks ovary suppression, and then give you replacement hormonal therapy, okay, sometimes patient call that long protocol, but it is different things. It is the protocol of endometrium preparation with agonists. Okay, also it depends. Me personally, I don't like such protocols, mostly never use. Try to use natural cycle protocols to embryo transfer with donor eggs. In case on menopause and when we have no own ovarian activity, I'm use mostly replacement hormonal therapy without these agonists. So, but articles show that there is no big difference. Only the difference may be during the pregnancy. With long protocol and egg donation, more complication like hypertension during the pregnancy.
All right. Thanks so much for the clarification. Now I think that it should be all clear. So thanks a lot for that. And there are some thank yous coming up. Thank you so much for all this information. Wishing you all the best. Thank you so much, everyone, for joining, for your questions. I do believe it was a great session with lots of interesting questions and, of course, answers. Dr. Halyna, it's great to have you. I know that we will be back soon enough. I'm already looking forward to it, as always. So thanks a lot for your time, for helping us with the questions as well. And as you can see, all the thank yous are coming up your way as well. And I couldn't agree more. So thanks a lot indeed.
Yeah, thank you. Thank you for your questions, for your interest to this topic. And it's true, this is a really difficult topic even for doctors. It's not easy.
There are many things in it, so you
Yeah,
need to
yeah.
remember about, right? So it's definitely not an easy one, but we were able to clarify it, I think, more or less, of course. And remember, we will be back on the 29th of November. We will talk about minimal stimulation protocol more with Dr. Elias Tsakos. I can only encourage you to join us then. So thanks a lot, everyone. Have a lovely evening, Dr. Halyna. Stay safe, and of course, I will see you very soon, I hope, as well, of course. Take care. Good night. Bye.
Bye bye.